If you do, great, Dr. Runtrack. We'll take it from there. All right. Go ahead, Dr. Cabrera.
All right. Good afternoon, everybody. I'm Brian Cabrera Valdes. I'm one of the PGY3 residents here in Westchester Mega Center. Today we'll be talking about to clot or not to clot, a very interesting trauma that came in to our trauma center, status post MBC. So I have no disclosures for my presentation. I would like to thank the Pan American Trauma Association for the opportunity to be here presenting today. And I would also like to thank Dr. Schneeman for the opportunity to be here, but not only that, also for the extensive mentorship he has provided me during my residency and training. So objectives for today, basically, we will discuss the relevant anatomy. We will discuss the techniques for operative management of the trauma, and we will evaluate the injury mechanism, associated injuries, and risk factors in this case. I lied in the previous slide. I have one disclosure. If you do not understand my accent for any reasons or I'm going a little bit too fast, please interrupt me. I'll be happy to repeat myself. So we have, to cut to the chase, we have a 19-year-old male who was involved in a high-speed motor vehicle accident. He veered from a highway 50 feet down an embankment with rollover. Airbags were deployed, had prolonged extrication time. EMS reported patient to be tachycardic and hypotensive at a scene with a systolic blood pressure of 60. So if you look at the left picture on the screen, you can see it's a picture taken from the highway down, and you can see where the car landed. Pretty significant fall. And this picture on the right is taken from where the car landed up, and you can see the sign of the highway up there. So it was a significant mechanism, had a significant force. So to make things more interesting, this patient has a history of hemophilia A. NTP was obviously activated based on EMS report prior to patient arrival. Upon patient arrival to our trauma bay, we performed a primary survey. Airway was intact. Patient was talking, a little confused. Bilateral breath sounds were present. Hemodynamically wise, he was tachycardic with a heart rate in the 150s and hypotensive with blood pressure 60s over 40s, at which point we decided to place a right femoral A line and a left femoral cordis, obviously undergoing NTP at this point. GCS was 14, sorry, patient lost 1.4 confusion. This is a chest x-ray obtained in the trauma bay, pretty much unremarkable at this point. No big signs of hemo or pneumo. The cardiac silhouette appears normal size. The mediastinum doesn't appear widened. And the midline structures such as trachea appears to be midline or non-displaced. However, pelvic x-ray also obtained trauma bay, we can appreciate multiple fractures. There are superior and inferior rami fractures bilaterally. We have a left wind fracture. We also previously had performed a fast exam, which was only positive in the pelvis.
Okay, let's go ahead and stop there. Okay, why don't you go ahead with that slide, and then we'll take comments afterwards. And also, if you can let us know, was he strapped in? Was he wearing seat belts? And I assume he was the driver.
Correct. He was the driver, and he was wearing seatbelt.
Good. Okay. So if you want to just finish that slide, and then we'll go around for comments.
Okay. So for secondary survey, we found a patient was found to have a blood at the urethral meatus with significant swelling to the left hip and left thigh. Had also an avulsion injury to the right buttocks and had abrasion and ecchymosis over bilateral hips.
Okay, so why don't we go around the room? So Dr. Frisbee, what do you think about this case?
I'd like to know something. How long, what was the time limit from the extrication to the time you started working?
So it was around 20 to 25 minutes.
Oh, okay. So you gave him a gram of Tex and you began your resuscitation. Is that right?
Correct.
And you knew this guy had hemophilia A?
Yes.
Oh boy. You know, is he holding on to his blood pressure?
So that's where I was going with the presentation. This was going to be my initial pause. Despite undergoing NTP, he continues to be hemodynamically unstable and labile, and his blood pressure, his systolic blood pressure drops to 40. So
Well,
what to do next?
you know his fast is going to be positive because of all those fractures in the pelvis, and he's got blood at the urethral meatus. So his he's probably got a bladder or urethral injury. At this point, you're going to have to be faced with the idea of at least doing something interventional to stop some of this bleeding. Now, whether you want to do preperitoneal packing, because I would be really loath to go right into the pelvis. Man, you're going to be in a world of the Red Sea, and we all know how that works out. It's not really good. So, what did you do? Did you preperitoneal pack him to try?
Well, let's wait until we all get to comment, and then.
Oh, I'm sorry.
Yeah, okay. All right, Dr. Hockman.
Oh, good morning. Okay, so you have this pelvic fracture. Obviously, he has a urethral injury. That's the main concern. The bleeding in the pelvis. Is the FAST positive or not? That's the part sorry I missed.
Yes, the FAST was positive only in the pelvis.
Only in the pelvis. Okay. So, well, okay. Several things here. I'm sorry. You took me a little bit by surprise, Dr. Untrack. I didn't think that you were going to call me. But he's hemophiliac, so I would try to get the factor is 7 concentrate if you can have it. If not, just first frozen plasma and cryoprecipitate, whatever I can give, trying to improve his coagulation profile. That would be the first thing. So if you have a patient with a bad pelvic fracture and a positive FAS, 70% of the time the bleeding originates in the abdomen, and the other 30% is from the pelvis that somehow the retroperitoneum got ruptured and is leaking into the abdomen. So I will start by putting a pelvic binder on this patient and see if that makes a difference. And after that, I'll probably prepare to go to the OR. And if I were to go to the OR, I will go with the laparotomy. If the patient stabilizes, probably CT or CT angio will follow by angioembolization of the pelvis. I'm pretty sure the bleeding will come from the pelvis. If you go to the abdomen and the bleeding is coming from the pelvis, what I have done in the past, and it works because you have to remember that the retroperitoneum is already open. That's the reason that you have the bleeding into the abdomen, is pack the pelvis from inside the abdomen. I extend the incision lateral to the bladder and rectum and pack the pelvis that way. The compression that when you do the preperitoneal packing happens because you have the bony pelvis around that cannot expand. The concern is that if you open the retroperitoneum, you are going to have bleeding into the peritoneal cavity. The peritoneum is open in that case already for you. So the only thing that you can do is to do the packing, and the packing is effective because you have the bony pelvis. So those are the few things kind of like you can try, but we'll see. Thank you.
Okay, Dr. Calderon, are you there?
Yes, I'm here. Can you hear me, Dr. Untrack?
Well, I can hear you. So why don't you tell us what you think? We can't see you if you want to turn your camera on, but
Oh, so I'm sorry. Yes, this is my ugly face. Okay, good morning. Yes, this is a very interesting case, an impressive accident. Well, he's hypotensive with a positive fast. I must suspect that it comes from the abdomen. Yes, so it was a good catch initiating the massive transfusion protocol, and I want to highlight the placement of the right femoral arterial line that can be later on used for embolization or for the placing of a RIBOA if you have it, okay? Well, my first step, like once we have, of course, placing the immobilization of the pelvis with a binder, of course, taking of the CT scan if the patient, we can catch up with the hemodynamics, but if we don't, we'll have to take the patient to the operating room. If you have an interventional radiology available in less than 30 minutes, he can come over to help us out with the hemostasis. If we don't, or if with the interventional radiology cannot come as fast as we can, I would do the laparotomy just to make sure that there is no bleeding or other injuries inside the abdomen. Even with that, I can help out with the pelvic packing, as Dr. Fochman said. So, well, with the bleeding stop, we can just get the help of the interventional radiology, we have him available, and the orthopedic surgeons, at least for external fixation on the pelvis. And I'm only talking about the pelvic injury. Of course, I will have to sort out if there is any other injuries inside the abdomen. Okay, thank you. That's all I have by now. Oh, yes, with a massive transfusion protocol, we are already giving the factors that an hemophilic patient may need.
okay, excellent comments. If I can just weigh in also, a beautiful case because, you know, if you think about the protocol, the algorithm for pelvic fractures, and Dr. Calderon, maybe you missed this part, but the intraperitoneal portion of the fast was negative. It was positive only for the pelvis. So you know that's a branch point on the algorithm. So in this case, you would try to avoid a laparotomy, and also the fracture does not look like an open book, more lateral compression, and so whether or not a binder would work is questionable. The external fixation might help, but I think that you know that I would be more concerned with the worsening hypotension, systolic pressure going from 60 to 40. He's probably tachycardic to about 140. And you did a beautiful job, Dr. Cabrera, in putting in early on the femoral A line and then a volume line on the left side. So I would, in this case, assuming that this is available to you, I would immediately, when I seeing the blood pressure drop and having all the other data, put a RIBOA in zone 3. And then while you're doing that, call in the interventional radiologist and try to get this clotted at the same time. You know, do the massive transfusion protocol, the anti-hemophilia factor transfusions, all of that. But right now, this seems to be localized to the pelvis, arterial bleeding from the pelvis. And you need every bit of help you can get because there are too many the comorbidity of hemophilia is a factor. And, you know, he's hemophiliac, so at least he was wearing a seatbelt. Probably shouldn't go over the speed limit, you know, if you're a hemophiliac. So, all right.
For those of you that opted to place the RIBOA, I'm curious, in this patient, you know, blood pressure is 40, imminently arresting. Would you place it in zone 1 or zone 3?
Good question.
No, I would do zone 3 because it's, you know, the bleeding seems to be from the pelvis. You've ruled out, it looks like he doesn't have an aortic fracture near the up in the chest, so you can put it in zone 1, but really zone 3 should do it. If zone 3 didn't work right away, then I might move it up. So that plus the transfusion, I think he would improve immediately, and then I would just get the, you know, especially if he improves, he needs the interventional radiologist to find the bleeding in the pelvis and clot it off. So that's my vote in this case. based on what you presented.
Okay, so I think since Dr. Ontrack spoke the last, I'm gonna follow his protocol. So we did put a REBOA. We upsized the right femoral A line with a 7 arterial sheath and placed a REBOA in zone 3. After which the systolic blood pressure improved to 90s immediately. So at this point, I know I have another stop here that says next step, but we have discussed multiple approaches. We have discussed going to the OR versus angioembolization. So I'm not sure if you have any other decision making
I
at
think
this
we can
point.
keep going. Yeah.
Like if you would like to explain where
Yeah,
which
so,
way will you go now?
we can go around really quickly one time, what to do, whether it's, you know, OR or angio, what everybody thinks. So we'll start Dr. Calderon.
Well, if you have an hybrid room, that would be the best place to take the patient. Otherwise, whatever you have if you have the interventional radiologist available, he can take the patient to his IR suite. I don't know if he will need the CT scan before doing the procedure. Otherwise, if we don't, we take the patient to the operating room for the pelvic packing. Well, I have to disclosure that I don't have interventional radiologist nor embolization in my hospital, so we take the patient for pelvic packing and the external fixation by the ortho surgeon. Thanks.
Right. Plus, you don't have REBOA, Dr. Calderon, right?
No, even when I have the training by the team of Dr. Carlos Ordóñez, we still don't have the REBOA. I already tried out many times because for that supply, but I don't have it.
Yeah, but in this case with the femoral A line, it was lickety split to put it in, I'm sure, and that's, you know, right. You were ready for this one, and so there are a lot of people, especially in the military, who just think the REBOA should go away. Tell that to this poor guy. But anyway, so Dr. Frisbee,
Yeah.
your choice, OR or angio?
Oh, if you've got the man that can embolize these things, I buy him dinner. I would. That's the guy you want. If you've got an interventional radiologist, that's the man that needs to give it a try. He really does. If he fails, you can always go in and pack him. But you really need this guy. Not everybody is going to have an interventional radiologist, and you're going to be forced to, you know, pack that pelvis.
Yep. Okay, and Dr. Hockman.
Well, I admit that I was a little bit confused at the beginning, but I understood that the FAST was positive. So that's the reason I say to go to the abdomen first. It appears to be the business in the pelvis now. So yes, pelvis is interventional radiology if you have, and if not, you do a pelvic packing. Yeah, I don't have anything else to add at this time.
Yeah, but okay, but so now that the REBOA is in, if he's better, would your choice be to send him to the angio suite or to take him to the OR?
His systolic blood pressure is in the 90s, so this patient probably the best option we have here, and again, this is something that we have here, and I understand not everybody will have this. We have a hybrid room.
Yeah.
So we can bring this patient to the hybrid room, and IR can start. If it's something else, we open. I don't know if I will send this patient to the angio suite because, first of all, it takes much more time to go to the angio suite than to go to the operating room until they get ready. They should be the puncture time in 60 minutes, and I think it's 60 minutes in a space where time goes much slower. So it all depends. I would not send this patient to the CT scan. I would love to have a CT scan, but with systolic blood pressure in the 90s, I would not send it to the CT scan unless I am strongly suspecting a head injury that might need to be addressed. Maybe I will bite the bullet there, but otherwise this patient goes to the operating room or the IR suite, whatever is safer.
Yeah, and I would favor the interventional radiology or the hybrid room, or in this case, blood pressure coming from 40 to 90 systolic. if it stays there, then I think you're good. And his Glasgow Coma score was 14 with a systolic blood pressure of 60. So he's mentally in good shape. And then if I were in a situation where there's no angio, like in Baghdad, we have Reboa, but no angio, or Dr. Calderon's case, because you have no intraperitoneal blood, but fractures of the pelvis and pelvic hematomas, then in this case, I would favor retroperitoneal packing without entering the abdomen, per the classical algorithm for pelvic fractures. But anyway, go ahead, Dr. Cabrera.
So we did have IR or interventional radiology available. However, we opted based on Dr. Hockman rationale when he mentioned that it would take longer period of time to take this patient to the IR suite, and based on the severe hemodynamic instability that the patient suffered prior to that, we decided to take the patient to the operating room. And in the operating room, we did perform a pre-peritoneal packing through a infraumbilical incision without entering the peritoneal cavity. And due to high suspicion also for intra-abdominal injury, we perform an exploratory laparotomy through a different incision, supraumbilical, and we found a sigmoid buccal handle injury, which requires sigmoidectomy. The abdomen was temporarily closed at the time. The patient was left in discontinuity, basically a damage control laparotomy. At that point, the reboa was deflated and removed, and patient remained stable at the time. So it's a picture of how we approach our pre-peritoneal packing. So we all know, start with the midline infraumbilical incision, all the way down to the fascia. We open the fascia very closely, not to very carefully, not to damage the peritoneal underlying peritoneum, and then pack the space of Ritz's with packing bilaterally to tamponade the bleeding vessels. Then since patient remained stable, we took the patient to the CT, in which head CT showed no TBI or skull fractures. Cervical spine was also clear, no fractures on CT. Chest showed multiple right-sided rib fractures and small right-sided hemothorax. However, no big hemothorax or pneumothorax was appreciated there. Interestingly enough, to make things even more complicated, patient was found to have extensive bilateral lobar and subsegmental PE with a right femoral DVT and duplex that was found later on. But to come back to the rest of the findings, abdomen pelvis, we saw, as we can see here in the 3D reconstruction, sacral ala fracture, sacrum fracture, bilateral inferior and superior pubic rami fracture, left iliac wing fracture, and left acetabular fracture. No femur or tib fib fractures were seen for their x-rays or imaging. We also obviously perform a CT cystogram based on the high suspicious for bladder or urethral injury, as we previously discussed. And we found extraperitoneal bladder rupture on this patient. So we did call orthopedic surgery to help us with pelvic fractures. We did call the urology service for management of the extraperitoneal bladder rupture, and hematology was consulted for hemophilia A management. So now it's post-update 1. Hemodynamics have normalized, base deficit cleared. We're in the ICU with an open belly, and we have multiple issues to address. So we have a PE DVT on a hemophilic patient that was in hemorrhagic shock 1 day before. We have the pre-peritoneal packs still in place, which, as we all know, it's a temporary measure to sort of like help with hemostasis, but it's not definitely. We have extraperitoneal bladder injury. We have sigmoid and discontinuity, and we have severe pelvic fractures. So what we will do next?
Okay, Dr. Hockman.
Well, I will start from the easier to the more difficult one. So the extraperitoneal rather rupture Foley and just leave the Foley for 10 days and that's it. I wouldn't do anything else. The sigmoid discontinuity, if the patient is getting better, it will stay that way with the open abdomen for at least an extra day. I will leave the preperitoneal packs in place for now and maybe address the pelvic fracture, which will be a problem because now it's contaminated. If the field, depends how they go, is contaminated with urine. That would be something ideal to fix because this guy is very, he can start bleeding again and kind of like it became the situation very difficult. And finally, what to do with the PE? I imagine that the PE is the consequence of the treatment for the hemophilia. Just unrelated to this, there were a few papers showing very early PEs in patients who present with trauma, that even some people suggested that the clots form de novo into the pulmonary circulation and they are not pulmonary embolus, but pulmonary clotting. I remember a paper from New England Journal of Medicine a few years ago. Patients who present with syncope, which is common after trauma, is not this case, but 1 in 8 has PE at the moment of presentation. So this is relatively common. The problem is that this guy has hemophilia. So I would probably talk to hematology, see what his whole coagulation profile is, and determine at that time if he needs anticoagulation or not. And because again, I don't know where this clot forms. Maybe it's just a result of the administration of whatever he got to reverse or to treat the hemophilia, and he doesn't need anything else, just leave it alone. But I don't know the answer. I will rely on hematology to provide me with what to do. Thank you.
Dr. Calderon.
Yes.
Yes, what would you do in this case? How would you manage these?
That's why my colleagues say, well, too many problems with these patients. Well, he is having a pulmonary embolism with DVT. We must already make a anticoagulation plan for this patient at some early moment. Yes, we can discuss if placing an IVC filter. I really don't know about it. I will discuss very closely this topic with the hematologist. That must, I guess, they are the primary physician. They usually the primary physician. Okay, so the preperitoneal packing, I will need to remove it at some point. The extraperitoneal bladder injury, is usually only conservative management with 10 or 14 days of Foley catheter. But one of the exceptions is when we have a complex pelvic fracture that needs to be repaired because they can contaminate the fragments of the bone at the surgical site. So it may need to be repaired also before placing the Foley definitive or doing a cystostomy. I don't know if it was possible to place a Foley catheter in this patient. Well,
he had a Foley catheter placed in the trauma area.
Okay, leave it there. Well, my opinion is that he will need to do a formal repair of that extraperitoneal bladder injury. Well, the severe pelvic fractures, very complex. That's the ortho guy's job. So good luck with that. Too many things to do with the patient.
Sorry. Audience, with the sigmoid resection, is anybody thinking about anastomosis, or is everybody bringing up a colostomy?
Excuse me, doctor. Yes, I forgot to speak about it. If the patient is stable and in good and fit for surgery, we can do the anastomosis. Otherwise, yes, keep it simple. Do the colostomy, terminal colostomy. That's all by now. Thank you.
Okay, Dr. Frisbee.
Oh, you would ask me. Let's see. I don't have any problem leaving the preperitoneal packing for the next 24 hours. And I don't have any trouble with the extraperitoneal drainage. What I really have a problem with And I don't care about it. You can put the colostomy in there if you want to, or just leave it alone for the next 24 hours. He's not going to need to go to the bathroom. So the point is, what are you going to do about that pelvic fracture? It's not just one fracture. He's in pieces, and he's going to get infected. The sooner you can do something about that, the better off the patient will be, because he'll be out of the realm of infective possibilities, hopefully. So you got to get with the orthopedic surgeon and encourage him to do the things that he knows how to do, and we don't. So that's the way I would do it. As far as this PE goes, I'd have to defer to the hematologist. A patient with classic hemophilia who throws a clot, if it is thrown, I tend to believe Horatio. I've never seen one of these, thank goodness. In all my years, I've never seen a DVT with a PE in a hemophiliac. It may be a consequence of over treating him for his hemophilia. There is such a thing to do. Everybody gets in a hurry and let's do it, and you give them a little bit too much, and this is what happens. But I would have to defer to the hematologist to give me some guidance in how to handle this. But that's all I've got.
All right, and based on what Dr. Hochman said, it seems like these clots were discovered within 24 hours of the injury, so they must have been pre-existing. And it seems reasonable. I don't have experience with this, but it seems reasonable that it's a consequence of his standard maintenance treatment for the hemophilia, that they were there before. And if these are pulmonary clots, not pulmonary emboli, then you would think that a vena cava filter would not be indicated in this case because they're not emboli. So, but I agree. I would rely on the hematologist that takes care of him about the treatment. About the other things, I think that I get the orthopedist involved early, and when they think it's ready for them to go in and do the reduction, whether it's open reduction, internal fixation. That he didn't have any fecal contamination because you were very prudent in picking up the bucket handle injury initially. So I think that they might be inclined with no obvious contamination. There's a bladder rupture, but it's extraperitoneal, and the urine should have been sterile. So I don't think that would be a contraindication to them. As far as the bowel discontinuity, I think it's reasonable to still leave it apart until you decide to close the abdomen in a day or so. But I would be, I'm a baby boomer, and I would be inclined to give him a stoma, but I would do it as like a Miculate stoma or Miculat's type stoma, so that to close it, you just do a local operation rather than another laparotomy. But I think the colorectal surgeons, and I don't know, maybe the trauma surgeons are getting more aggressive. And, based on his condition and how much he was transfused, you probably gave him more than 8. You didn't say how many units of blood you gave him, but you shouldn't do an anastomosis for someone who's been massively transfused, an acute anastomosis. And I think that if you did that and it didn't work out well, and somebody who's got medical complications, medical pre-existing illnesses, you'd be subject to criticism, but no one would criticize you for leaving basically a loop stoma or Miculat's type stoma. You get off scot-free with that one, and you sleep well at night.
Okay, so we sort of like approach it in a mixed way with what everybody said. Basically, we took the patient to the OR post-op day 1 because patient was fairly stable in the ICU. Hemodynamics had normalized at the point, his base deficit clear. So vascular came in first, and they placed an IVC filter to avoid any further propagation of the DVT. into further PE or evolution of PE. Then we removed the pre-peritoneal packing, and we found no significant bleeding. So all the bleeding vessels at the time were tamponad. Interestingly, so we had already sent the culture swabs for the labs, and it came colonized already for MSSA. So I'm assuming that based on this case and the extensive injuries he had, plus the bladder rupture, the orthopedics surgeons were a little bit more conservative in their management at the time. They didn't go acutely. We had our urologists to perform a bladder extraperitoneal bladder repair with drain placement, just for to eliminate the possibility of further contamination of the repair of the orthopedic injuries, which had to be addressed in the future. And we performed sigmoid colostomy. So we brought up a colostomy based on the fact that the patient was, even though he was hemodynamically stable at the time, he just underwent master effusion protocol the day prior with significant hemorrhagic shock. So we did not opted for a primary anastomosis, and we closed the abdomen.
Did you, the colostomy, was it kind of a double barrel colostomy or just end sigmoid colostomy with a pouch?
We brought up just an end colostomy. This time we were not trying to win any more points. We were happy the patient was alive and doing well. And so we thought the simplest thing would be best. And the other decision for bringing up the colostomy was not only about the hemodynamic stability the day prior, but, this gentleman with severe pelvic fractures, we know he's not going to be ambulatory. We know turning him is not going to be fun. So we knew this would be the situation for the next few months as he's healing from his pelvic injuries. So we thought the colostomy would be best for him in all sorts of scenarios until he can heal up and get better.
Yeah, let me ask you, would it have been difficult to bring up the distal end as a double barrel or easy? That's another consideration. Was did the resection leave you with a short efferent limb, or was it long and floppy? So
it was pretty long. I think it would be doable.
Okay, all right. Okay, go on, Dr. Cabrera.
Does Dr. Hodgman have a question? Or
I think Dr. Hogman has a question.
No,
Okay.
just two quick comments. I agree with this approach, as Dr. Untra said. We do this not because we are old, but because we have experience. This is a patient is already too complicated. If you have a leak post-op day 5, you are really in a lot of trouble. So keep it simple. You got too many things to deal with. Colostomy, the way to go. Regarding the pelvis, I'm not an orthopedic surgeon. I wish we have one of my orthopedic surgeons here, but cases like this, what I have seen is they put the screw posteriorly to fix the posterior component, and anteriorly they do an external fixator, and that will buy you time, and you don't have to. I do my own repairs of the bladder, but I don't do extraperitoneal bladder repairs. We usually don't repair them, we just leave a Foley. This is an interesting approach. I really like it. I might consider to do it in the next case I have like this.
yeah, that's
Particularly
exactly
when you
the
have opened the
strategy.
retroperitoneum already. It's all open, so it's very interesting. Maybe
Yeah.
we'll do this.
Traditionally, we would absolutely manage the extraperitoneal bladder injury with just a Foley, drainage, and repeat a CT cysto in a couple of weeks. But in this case, with all the extensive pelvic fractures, orthopedics didn't want the repair bathing in urine. And so since we were already going back, we were already in the space of Retzius to take our preperitoneal packs out. It was easy enough to do a quick extraperitoneal bladder repair.
It makes a lot of sense. Dr. Calderon mentioned that too before, but this is the beauty of this. Opens your minds to different options.
Okay, so from post-op day 5, we brought the patient back to the operating room for a debridement of the midline laparotomy and wound back placement. And we also drained the left pelvis/thigh Morel Lavelle lesion that he developed during this trauma. And then on post-op day 8, the final fixation by the orthopedic team happened. with another combined procedure that we basically debrided the midline laparotomy again and replace the wound back with revision of the Morel level lesion. So eventually, the Morel level lesion closed, and we performed a delayed primary closure of the abdominal wound. We did discuss extensively with the hematology team about anticoagulation management for this patient. He did not tolerate and develop a GI bleed. So, but he did tolerate DVT prophylaxis during hospitalization, and he was then discharged on post-op day 45. I would like to talk a little bit about the hematology management of this patient, and obviously, like very complex patient with hemophilia A who came in hemorrhagic shock, multiple pelvic fractures, with DVT-PE on arrival. We already more or less discussed, I think, the hospitalization course and the way we treated the injuries and the different interventions we did and the order of it. However, I'm just gonna talk a little bit about hemophilia A and what it is. Basically, it's a factor A deficiency. And has two different types, basically congenital versus acquired. Congenital is the most common one, 80% of the cases, and it's indeed provoked by a factor A deficiency. And the severity of the disease depends on the type of mutation that the gene suffers. So basically, if you have a point mutation in which you have like a single amino acid replacement, the protein is going to be mostly functional, and it's going to be the phenotype of the disease is going to be very mild. Versus if you have a missense mutation in which you basically have the whole frame shift of the protein is completely changed, and it would result in a almost whole different protein with no functionality in the coagulation cascade. However, but either way, the treatment for congenital is supplementation of factor VIII. In our case, we gave extended half-life factor VIII, which bind to the FC region of the protein. And for acquired, which is less common form of hemophilia, it's caused because of antibodies against factor VIII. So the treatment varies because if you continue to give factor VIII, the antibodies will continue to bind it and render it inactive. So the treatment for it give bypass products, and bypass products, what I mean is that bypasses factor VIII. So you give activated factor VII. You could potentially give to porcine factor VIII. Because it's not bound by the antibody, by the human antibody, and steroids. You basically treat it as an autoimmune disease, and you give high dose steroids for it. These are a couple of papers that I found in the literature, basically comparing Reboa versus preperitoneal packing interventions if patients with pelvic fractures. And in this particular study, the Reboa group was found to have lower 24-hour mortalities and lower in-hospital mortality when compared to the other groups. However, we need to be realistic and realize that these are retrospective studies, and even though matching it's used during the methods of the papers and all of that, just by definition, because of the way the study is conducted, you get like non-comparable groups baseline, and you always will have a little bit of selection bias. For example, patients who underwent Reboa plus preperitoneal packing are usually way sicker than the patients who underwent only Reboa or only pre-peritoneal packing. Another study that I found in the literature that was interesting enough because it has, I would say, different results from the previous one is different intervention, again, or hemorrhagic control interventions in patients with pelvic fractures and hemodynamically unstable. And interestingly enough, in this study, the mortality by angioembolization was lower, and then only followed by pre-peritoneal packing. Reboa was found to have a higher mortality use when you compare like Reboa zone 3 only, which is the initial intervention that we provided. Obviously, patients that can directly go to the angioembolization room are going to be less sick. So again, there is a little bit of selection bias in this type of studies. Because you do not have to perform any intervention and the patient it should be stable enough to go, versus patients that are taken directly to the OR are probably more sick, or patients that underwent Reboa placement in the trauma bay.
Can I would just ask a question before you leave that slide?
Yes.
So Reboa only, zone 3 only. That, what does that mean? Because Reboa zone 3 only is not a definitive treatment. It's just a temporizing measure. So what you have to, once you do that, you have to do something else. Presumably the patient either stabilizes or doesn't stabilize. The ones that stabilize with Reboa in zone 3, they either need embolization or packing like you did in this case, So what does that mean in those studies? Which I assume are also retrospective as well, right?
Yeah, correct. It's a retrospective study too. Yeah. So in what they mean by Reboa zone 3 only was basically like patients that came into the trauma bay where Reboa was placed as a temporizing measure. They either stabilize after the intervention. I did not require any other form of intervention after that, because they did a split. You can see that the mortality is extremely high. So most of those patients did not stabilize, and the rest of the patient population was also stratified in Reboa placement, but with further interventions, as we can see in these arms of the group, basically.
Okay, so maybe those patients Reboa only, they put the Reboa in, then they didn't improve, and then they didn't survive the acute phase, perhaps. So okay, that makes sense.
Probably 50% that, and 50% didn't need the Reboa.
Yeah,
correct.
Okay, all right.
All right, so patients was seen subsequently in clinic and underwent ostomy reversals with no complications. Recent duplex show no DVT, and patient is still pending for IVC filter removal. And our patient is happily now buying toilet paper at the time.
Yeah, it was interesting. We left the IVC filter knowing that we would be reversing his ostomy in the future, because he's a young guy, so we knew we would get to that point eventually. And I just reversed the ostomy a few months ago, and everything went well. But you know how we leave the old ostomy site open and we have the patient pack it? He developed such severe hemorrhage, he had to come to the emergency room to control the hemorrhage from the subcutaneous tissue. Like, his hemophilia was very, very severe. He actually, even prior to the MVC, he takes factors at home every single day. And when he was in our hospital here, his father, he has 2 kids, both sons have hemophilia, unfortunately. He had to drive the son's blood to a special lab to undergo some special testing. It was a very interesting case from the standpoint of hematology as well.
Wow. Man, he has brittle hemophilia.
Yeah, with the CRISPR therapy, probably.
That's what I told him. He's going to get cured with CRISPR.
Yeah, his kids, his sons, you expect all the sons to have hemophilia, but his his son's sons may be okay. There you go. They'll be cured, and then whatever. So if you can just comment, Dr. Cabrera, as Dr. Hockman said, is this typical? These patients tend to have pre-existing, or they tend to walk around with clots, or it's not related to the trauma itself, but just related to his hemophilia treatment. Is that correct based on your reading?
So basically, yes, these patients have some degree of coagulopathy baseline that needs correction, and therefore they are a higher risk for developing either hypercoagulation or hypocoagulation disorders. Their baseline hypocoagulative risk, that's sort of like the same. Not the same, but similar concepts of patients that have liver disease and are severe coagulopath that also may shown with hypercoagulable disorders secondary to their liver disease.
Right. And even though those intrapulmonary clots are not really emboli, that doesn't mean that big DVT that he has can't propagate and shed emboli. So I guess that was a good call to put the filter in. And then one other issue. So in this case, you did the laparotomy based on just the fact that it was severe trauma. Once you stopped the bleeding, you wanted to be absolutely sure despite the negative intraperitoneal fast. Is that right?
Correct. So it was a high speed mechanism. We had high suspicion for intraabdominal injury, even though the FAST was negative, but based on the associated pelvic fracture that he had, and since we were in the operating room already, and the patient was hemodynamically stable after the packing, we decided to explore the abdomen just to ensure that there was no missed injuries, which in his case will potentially be fatal.
Yes.
Yeah,
Yeah,
very difficult.
very good call.
Very
good
difficult
call.
to tell on the pelvic fast. You see the peritoneum and you see some fluid. Is it intraperitoneal, retroperitoneal fluid? And given the hemodynamic instability, obviously, we just felt exploring the abdomen.
You can't be sure, right? If it was a grossly positive intraperitoneal fast, you would have started with the laparotomy first. This time you started second. And then if you hadn't done the laparotomy, presumably you would have done a CT scan that would have raised red flags within, immediately, and you would have gone back. But excellent.
Well,
and then
he also had he had a torn mesentery. So, I mean, it wouldn't take you very long to figure out that, hey, man, this guy is bleeding internally. We got to go back.
Yeah, you would have seen fluid, bowel thickening, whatever. And before we go around, just did you ask him why he was speeding so much? Why was he going so fast? I mean, well, don't do it again. Keep wearing the seatbelt.
I don't care about this. I don't care about the speed. Just keep your eyes on the road, man.
He's 19.
He's got two sons. He's
right.
Not only got hemophilia, and he's got two sons. Set a good example. Whatever. But anyway,
the speed limit on our highways here in New York is 55, but most people drive about 80 on average.
Yeah.
Sure.
Yeah, but I mean, don't get a Tesla. Set the thing for hematology mode, and then for hemophilia mode. Okay, final comments. Why don't we go around, Dr. Calderon?
Yes, good case. Very interesting. The Pan American Trauma Society is scheduling these trauma and acute care surgery courses. The next module in November is about severe pelvic fracture. So this conversation will be very useful. I'll give you another point of view. When we have these severe pelvic fractures with FAST negative, after the patient is stabilized in the operating room with pelvic packing, X-fix, whatever, and if we don't have the CT scan, sometimes we at least do a laparoscopy, diagnostic laparoscopy, instead of taking the patient to the CT scan or returning back to the OR. That is not easy. Well, with a negative laparoscopy, we just close the belly button and we forget about the patient. Well, I'm of those surgeons eager to do a deferred in this guy is going to make easier the postoperative care. So that was a good point. Yes, thank you. That's all That's all my thoughts.
Yeah, yeah. In my day, I think Dr. Hockman would appreciate that. Maybe Dr. Certainly Dr. Frisbee. I would have done in the ER, and this is before FAST, and even with a negative FAST, you don't know if it's a true negative. I would have done a peritoneal lavage, which is the poor man's laparoscopy. You would have gotten some blood right away and said, okay, no, we gotta have a look. But excellent point about, you know, because I picked up bucket handle injuries in someone that didn't have any peritoneal signs, or they were not conscious, and just by peritoneal lavage. And so excellent point. Okay, Dr. Hockman, final comments.
Excellent case. I learned a lot today. I kind of like the repair of the extraperitoneal bladder rupture. It opened my mind to consider something like this in the future. So that was very good, very good. Thank you.
Yes, and Dr. Frisbee.
You know, I've done this for 39 years. It'll be 40 in June. And I always look forward to this week. I always look forward to Monday. I never used to, but this is because of this. I always learn something about it, and today is no exception. It was an excellent case, very well done.
Yeah, you know, it really, it's a case that makes your hospital look great, and you can really be proud of this one. I don't know why you waited so long. This obviously happened last winter based on the initial photos you showed. But the only way you can make your hospital look better is to retake that picture with the sun out. But, you know, really, I mean, your PR people are looking at that and said, "Oh my God, what are they doing? They're going to get you a better picture." Well done. Beautiful case. It was really very interesting and enjoyable, and some very good pearls that we all learned something from this. Great job.
Thank you very much. Thank you for having me.
Thank you,
everyone,
Dr.
for having
Cabrera.
us, and,
I put the CME information in the chat earlier. I'll leave the meeting open so people have a few minutes to get that information. Thank you again, Dr. Cabrera.
Thank you very much for having me.
Kevin, last time when I tried to log in was asking me for the meeting code. It's in there. It's in
Yeah, it's the activity link. So like in this case, or the activity ID, I should say. In this case, it would be that the last 5 digits. It's that 18658. That's the activity ID.
Perfect.
It should pre-populate it, but if for whatever reason, if it doesn't, it's the last 5 digits.
Okay.
Thank you very much. Thank you.
You're welcome.
And Dr. Untrach, if I might answer the question about the 19-year-old, because he's 19 years old. I always say, I'm joking, that's a glass ceiling that woman will never break. It's doing stupid things age 18 to 35. Men, we will always beat them at that. And even when we get older, we continue to do stupid things. So
yeah, he's 19 years old and has 2 sons.
Well, some
No,
things
the
are.
patient is 19. His father is probably in his late 50s, 60s.
Okay, so he has a brother.
Yes. He has a brother.
Okay, very good. Oh, well, that explains it. So if he wants to have 2 sons, slow down. I don't know why. I would ask him, why do you do that? Just don't do that.
He goes fast at everything.
He should, whatever. But he wore a seatbelt. With that, you look at those wounds and the way that car looked without the seatbelt, you know, you wouldn't be presenting this case.
Exactly.
Okay, so well done. Okay.
Thank you, everyone.
Nos vemos, Brian.
Thank you, everybody. Bye-bye.
Yeah. Do svidania.
Do svidania.
Mir.
Sei gesund.